I'm Dr. Prasanna. I'll be presenting a long case today. So, the patient allotted to me was a 27-year-old male Mr. Balakrishna, who was a resident of Khammam district, working as a nursery school teacher, educated up to B.Ed. The informant is self. He was admitted to NIMS hospital on 13/8/2023 and examined by me on 18/8/2023. So he is a live-related renal transplant recipient, now presented with chief complaints of vomiting, multiple episodes since 1 week, associated with abdominal pain since 1 week. History of presenting illness. I would like to date back my history to December 2022. Before this period, the patient was apparently normal. He was first symptomatic in December 2022 when he reported to an outside hospital with complaints of nausea and vomiting for 15 days. The vomiting was non-bilious, non-projectile and not associated with any abdominal pain. The vomiting was associated with headache, which was holocranial, not associated with any blurring of vision or focal neurological deficit. With the above mentioned complaints, he was evaluated at a local hospital where he was told to have a hypertension with a BP of 200 by 110 millimeter of mercury with renal dysfunction and a creatinine of 8 milligram per deciliter. So from this center he was referred to NIMS for further evaluation and during this period on questioning, the patient did not have any history of fever, sore throat preceding this illness, no history of any oliguria, anuria, no history of any swelling of legs, abdominal distension, no history of any facial puffiness, no history of any breathlessness, no history of rash joint pains. To NIMS, he was initiated on HD via right IJV non-tunnel catheter. After 2 sessions of HD, he underwent a renal biopsy without any post-procedural complications. And after the biopsy, he was able to convey that the treating physician has told that he has a disease called IgA nephropathy and it has led to 80% damage of the kidneys. So he was after this biopsy, he was advised to undergo a maintenance hemodialysis and he was also discussed on options of live-related renal transplantation. After this, the patient continued on HD via right IJV non-tunnel catheter. In the meantime, he underwent a left RCAV fistula creation, through which the dialysis was continued after a 2 months dialysis vintage. He continued on MSD at his nearby hometown. After a dialysis during the dialysis vintage period of 3 years, he received 3 units of blood transfusion. He had a history of he had a residual urine output of 250 ml per day. And he was vaccinated with 2 doses of hepatitis B and no other vaccination he has received. He did not have any history of intradialytic hypotension or hypertension. His intradialytic weight gain was 1 to 1.5 kgs. During this dialysis vintage period, he was simultaneously evaluated with mother for a live-related renal transplant. His mother was a 50-year-old female belonging to the same blood group, O positive. After a hematological and immunological workup, he underwent ABO compatible live-related renal transplantation on 16th of May 2023. So he was not told about any intra complications and he was shifted to KTU in a conscious and extubated state and he was told to have a brisk diuresis. He was able to convey that he received 1 costly injection on the day of surgery. And his post-op course was uneventful. On further questioning, he told that he had a history of hyperglycemia detected on post-op day 5, for which he was started on insulin twice daily. Other than this, he was doing good and was discharged on post-op day 8 with a creatinine of 1 milligram per deciliter, and he was able to tell his discharge medications, which were Visalone 20 mg, tacrolimus 2.5 mg twice daily, and MMF 750 BD. He was also treated with he was also given Valgan 450 OD and Cotrimoxazole tablet. So after discharge, the patient was on regular follow-up to the transplant OPD and was doing well till 1 month post-transplant. In June 2023, he was admitted in view of asymptomatic rise in creatinine to 1.77 milligram per deciliter from 1.1. On questioning, he told that he was adherent to the medications and there was no history of any fever, loose stools, dysuria, oliguria, or hematuria, or any graft site tenderness during this preceding this illness. So during admission, patient was started on IV fluids and other medications, and he was able to convey that he underwent a TAC level, and which was told to be high, and his TAC dose was reduced. So after this intervention, the patient had creatinine normalized to 1.2 milligram per deciliter, and he was discharged in a stable state. So after 15 days of this event, he was readmitted again with asymptomatic creatinine of 1.6 milligram per deciliter. His previous visit, creatinine was 1.2 milligram per deciliter. So during this period also, he was adherent to medications. He did not have any issue of fever, loose stool, oliguria, hematuria, dysuria, or graft tenderness. So during this admission, he was advised for graft biopsy, and the procedure was uneventful. On discussing about the graft biopsy, he was told to have a mild rejection, and he is able to convey that he received 3 doses of Solomental injection, 250 mg over a period of 3 days, after which the creatinine reduced to 1.3 milligram per deciliter. The patient was symptomatically better, and he was discharged with a creatinine of 1.3 milligram per deciliter. So he was doing well till August, first week of August, during when he developed multiple episodes of vomiting, non-bilious, non-projectile, associated with crampy abdominal pain for 3 days. During this episode, he had history of multiple episodes of loose stools, 3 to 4 episodes per day, which was watery in consistency and non-foul smelling. There was no history of any fever, oliguria, or graft tenderness associating this illness. And he was admitted and told to have a creatinine of 1.6 milligram per deciliter. He was treated with IV medications and IV fluids. During this hospital stay, he was able to convey that he underwent a CMV PCR test, which was told to be negative, and his immunosuppressive dose, MMF dose, was also reduced. He symptomatically improved after 5 days, and his discharge creatinine was 1.36 milligram per deciliter. But he was discharged only to be readmitted after 3 days, again with relapse of symptoms and raise in creatinine to 1.5 milligram per deciliter. So right now the present hospital stay is symptomatically better with IV medications and IV fluids, and his MMF dose was reduced to 500 mg BD, and he is on a TAC dose of 1.5 mg BD and Visolon of 10 mg. Moving on to the past history, there was no history of any TB, thyroid disorder, no history of any CAD, CVA, seizure disorder, no history of any comorbidities like diabetes or diabetes. He was hypertensive since December 2022. He is not taking any antihypertensive medications post-transplant. Personal history, the patient consumes a mixed diet. He is a non-smoker, non-alcoholic, no history of any substance abuse. And drug history, he denies to have taken any native medications in the past, and now he is complement to the medications which he is taking. His birth history and family history, he was born to a non-consanguineous married couple, he was a second born male child, born out of normal vaginal delivery, cried immediately, no history of any neonatal ICU care. He had a normal scholastic performance, and no history of any renal dysfunction in the family. His father died at the age of 60 due to chronic liver disease secondary to alcohol abuse. He is married and blessed with one child who is 3 years old. Shall I summarize? So, physical examination, the patient is conscious, coherent, oriented to time, place. The patient was thin built, his bone BMI was 19.9. There was his oral cavity was normal and oral hygiene was maintained, no ulcers or gum hypertrophy or tremor. Yes, ma'am. Positive examination. I think only right iliac fossa scar was seen, that's all. Upper abdomen is soft, no tenderness. Fistula is jugular. He is having a functioning left RCA fistula with skin marks of previous right IJV. Biopsy mark. His blood pressure was 120 by 80 millimeter of mercury in bilateral upper limbs. No radial or radiofemoral disease. No, not on any antihypertensive at present, but previously before transplant he was on Arcamin and no, post transplant he is not.
Is it important to know about the antihypertensive or not?
Yes, sir.
Particularly when you are examining a patient, so renal transplant patient. So most of the times the patients know everything about drugs.
If patient is on multiple antihypertensives or sudden onset of hypertension, we can suspect of renal artery stenosis.
Also it is important that happens. So summarize your history examinations and tell us the provisional diagnosis.
So summarizing, 27-year-old gentleman, live-related renal transplant recipient, first diagnosed in December 2022 with renal dysfunction and hypertension, underwent a renal biopsy, told to have IgA nephropathy with probably 80% IFTA, underwent with a dialysis vintage of 3 months with a history of 3 units of blood transfusion during this period, underwent a ABO compatible live-related renal transplantation with mother as donor on May 2023. With history of hyperglycemia on post-op day 5 managed with insulin, and post-transplant events of asymptomatic graft dysfunction, 2 episodes, one associated with increase of elevated TAC levels and other secondary to a probable rejection, probable TCMR, with the present admission of acute gastroenteritis and acute graft dysfunction.
Acute
Graft dysfunction.
So no reason for acute graft dysfunction.
Sir?
Any probable diagnosis for acute graft dysfunction, sir?
ATN only.
You are thinking of it?
ATN.
Okay. So this was summary. So
Yes.
tell me about the provisional diagnosis of this patient.
So provisional diagnosis is CKD-T, native kidney disease, CGN, IgA nephropathy, ABO compatible live-related renal transplant recipient with post-transplant complications, PTDM, probable CNI toxicity and history of TCMR, and acute graft dysfunction with secondary to AGE, probably ATN.
Secondary to AG.
Acute gastroenteritis, now present with acute gastroenteritis.
Okay. So diagnosis was IgA.
Yes, sir. Native kidney disease. Right.
So what is the usual course of the IgA nephropathy, which leads to end-stage kidney disease? Usual course of, suppose you see 100 patients of the IgA nephropathy, it is one of the common disease.
Usually they present with in the second decade or third decade, sir. They start presenting in the second decade, other than IgA vasculitis where they can present in the early second decade also, and they can if with proper intervention they can sustain up to third or fourth decade. Most probably they can progress to ESRD in third or fourth decade of life.
Everything in third and fourth decade.
Sometimes beyond that.
No, so usual course of the IgA nephropathy, it is slowly progressive disease or faster progression happens in this
Yes,
disease?
it depends on
And how many patients at the first presentation can have the end-stage kidney disease? Like you have told us 80% IFTA. Why
Yes.
you are telling IFTA 80%? In your summary, you have...
He himself told that the treating doctor has told that he is suffering from IgA nephropathy and there is damage of 80% of the kidney. I presume it to be IFTA.
Why you are presuming it to be IFTA? So you think this is a primarily the interstitial disease?
You can justify it.
Yes, sir. All glomerular disease.
This patient went on to dialysis soon after that, isn't it?
Yes.
So there is likely to be a lot of chronicity.
You should expect this was a chronicity which was observed. Majority of the time it is the diffuse glomerular sclerosis, not this diffuse glomerular sclerosis is there would be IFTA. When you talk about the IFTA, you talk about the recessive fibrosis tubular atrophy. Okay? So Majority of the time, this is not an interstitial disease. IgG nephropathy interstitial disease.
No, glomerular.
Hello. Hello.
Huh?
Check. Hello.
Glomerular.
Hello.
So it is glomerular disease. Right? So glomerular disease usually progressing to end-stage kidney disease asymptomatic. Yeah? First time came, you have done the biopsy, and then patient had end-stage kidney disease. So this is the usual course.
No, so they can have a preceding illness of suggestive of any glomerular etiology like proteinuria, swelling of bilateral legs, or hematuria. Usually the presentation is like this.
So what are the common presentation of IgA nephropathy
At the start.
at the start?
Most common presentation is asymptomatic microscopic hematuria, and followed by asymptomatic urinary abnormalities, followed by macroscopic hematuria, and other presentations can be an AKI or an RPRF or
What's the most common presentation pediatric age group for IgA?
macroscopic hematuria.
Synpharyngitic.
Synpharyngitic
eosinophil.
macroscopic hematuria.
The current microscopic imaging.
So patient can have asymptomatic hematuria, macroscopically, asymptomatic urinary abnormalities that you can say. So then patient can have the nephritic syndrome, can have nephrotic syndrome, can have nephrotic nephritic syndrome, can have RBRF-like presentation, presenting transformation. So you should know about these are the different syndromes through which these patients can present. And usually the broader groups, larger groups who are asymptomatic will progress. What other glomerular disease which can progress so silently to end-stage kidney disease? Any other glomerular disease which can also progress to
FSGS also sometimes, and C3GM also.
FSGS, some of the patients, some group of the patient can have subnephrotic proteinuria, not that much agitation like this, and nephrotic syndrome can progress. Agree. So here you have the patient has already told you I have IgA nephropathy. So that is the most easy explanation of the nitty-gritty disease.
If that biopsy report is not available, what will be your differential diagnosis? Biopsy
So-
was not done,
Yes,
or
ma'am.
patient is
If,
not known.
First on CGN I would first consider MPGN pattern progress to ESRD.
How can you say this is CGM? He has
Not-
hypertension and creatinine 8
Hypertension, yes.
milligram, that's all.
Yes, ma'am.
Totally asymptomatic.
Yes, ma'am. I'll also consider other CTIN also, where
CTIN
sorry,
presenting with
CAN.
hypertension 200.
sometimes chronic interstitial nephritis presents as ESRD can present with hypertension,
Okay.
or
Which category of CTIN can have the severe degree of hypertension?
Hypertension and
We were-
significant asymptomatic proteinuria.
VUR and ADPKD can present with
Reflex nephropathy.
Sorry.
Reflex nephropathy. One of the immediate DD of a CTN, isn't it?
When you say BUR, when you say reflex nephropathy,
Both are the same or different?
Reflex nephropathy, it is a clinical syndrome. VUR is also a cause of reflex nephropathy. Even a neurogenic bladder also can lead to reflex nephropathy.
Now, what is the difference between these two terminologies?
do you think all BUR leads to reflex nephropathy?
Yes, ma'am. Presenting with renal dysfunction is reflex nephropathy. Presenting as hypertension or
See, what the clinicians do to demonstrate the patient had reflex nephropathy. These are the some terms you use very casually, but there are a lot of meaning of this. BUR is very common, and reflex nephropathy. Do you think all BUR leads to reflex nephropathy? What the clinicians do to demonstrate that this patient would have likely to have this reflex nephropathy?
investigation.
Examination, investigations.
Investigations MCUG can be done to diagnose.
So that is you to do to see only reflex.
Yes.
Nephropathy means
to DMSA you can do. To
Involvement of the kidney happens there. So,
renal scarring can be.
so DMSA is usually done to see the scar. If you are demonstrating the scar on this, then the people say, and subsequently these patients might have many scar can be demonstrated, but might not have the hypertension, or mild hypertension can be there, might not have the protruria, but might be the protruria there. But a scar, demonstration of the scar, usually if it is seen by any nephrology, they demonstrate probably disease or probably reflex
Can you
nephropathy.
tell me a typical scar in reflex nephropathy?
It will be involving the upper poles.
Why is
Then?
Poles, sorry.
Why polar scar, sir?
Sir, there are usually two types of papilla, ma'am, conical papilla and compound papilla. Usually when there is a reflex, there will be a water hammer effect. This compound papilla cannot contract, so all the urine will be forced to the upper and lower poles, which are where the compound papilla are present.
that called?
Water hammer. Bo-
And the other type of reflux, you have vesico-ureteric reflux and
Intrarenal reflex.
Intrarenal.
Are you not surprised that a glomerulopathy has just remained silent without frothy urine, without edema? Is it possible at all?
Yes, sir. Sometimes they can present as indesiccating.
So how could he remain non-oliguric despite there being such a severe chronicity warranting immediate initiation of dialysis and transplant within 2-3 months? So this is a point to ponder over.
Yes, sir.
So it depends on the proportion of the tubular decision.
Tubular decision.
Okay. Whenever, as Professor Srilata asked, that question is very important. Biopsy report is not available to you. A young person, in mid-20s, comes to you with such a severe hypertension, 220, 120. And again, in the clinical examination, your examination is not complete if you have not mentioned about fundus.
Yes, sir.
Very important.
Yes.
And the two, a person who has been having pre-transplant, such as severe hypertension, post-transplant BP normalizing, I would like to think that his volume loss is so severe because of AGE and
Okay.
it requires some urgent attention. Normally, the BP continues. There are very small subset of the patients, the BP becomes better after transplant. Usually, the BP worsens. Particularly IgA nephropathy, BP continues. So hypertension continues.
why does it continue? Just small.
Why does it continue?
Secondary hyperinemic state.
But why is that hyperenemia then? If there is hyperenemia, you have to prove that. But what caused that hypertension in the first place? What was responsible?
Angiotensin II.
Where is that? Where is all that coming from?
Coming from?
Until
Our salt and water irritation is thought to be because that went down with the diuresis.
That's the question. Where does it come from? Why it continues?
Came from
Liver.
the
Native kidney.
and the native kidneys are still there after the transplant. You don't remove them.
yes.
So therefore, that is why he said
That's very
it's
important.
expected that this will continue after transplant. It's not very common for it to totally disappear.
The examination of all the peripheral pulses is important. Whenever a young person with severe hypertension, number one, examination of the cardiac apex is important. Examination of the funda is very important.
Sorry.
You may have positive finding, you may not have positive finding, but please remember this,
Yes.
the comprehensive examination is important.
Yes.
That is number one. Number two, when you come across such a severe hypertension with advanced kidney failure, keep your options open.
Yes.
One, glomerular. Very peculiarly, Indian IgA nephropathy is different from the Western world IgA nephropathy. So in fact, Professor Fiheli, he even jovially comments that Asian IgA nephropathy and Caucasian IgA nephropathy are two different diseases, That advanced severe form of IgA nephropathy is reported almost all these centers. That is number one. Number two, always think of certain vascular causes like
TMA.
TMA. So ruling out TMA. Suppose a biopsy is not, you are not able to perform biopsy. Before going ahead with kidney transplant, better to go for genetic
Genetic.
testing. Because you need to counsel, prognosticate, assess the chances of recurrence post TMA.
Yes.
So because we are clueless, right?
Yes.
Severe
Yes.
Second. Third thing, still it can be chronic tubular interstitial disease when there is a reflux nephropathy. And even if you do MCU, you may have a reflux, even the reflux might have disappeared also. It does not work. So in such a situation, all these things are possible. Okay, so that is number one. Number two, can this be a monogenic hypertension?
Very rare, sir.
Have you come across monogenic? Please remember this point. So we are underdiagnosing monogenic hypertension. The only clue in the early stages may be hypokalemia. But with the advanced kidney failure, the potassium normalizes, we may miss out. So that also, because there's no reason for this young gentleman without any family history going for such a severe hypertension causing rapid kidney damage. So all these possibilities have to be there. But fortunately here you have IgA diagnosis. Okay. So we think IgA, again, it's a heterogeneous disease with a different natural history, right?
Yes.
He belongs to what category? Rapid progression.
Rapid.
What is the implication post-transplant? Because this point has to be counseled pre-transplant, it has to be documented also in your counseling.
So according to
What are the implications?
15% of IgA nephropathy can recur after 10 years of post-transplant.
Yeah, one of the risk factors is the early progression to ESRD stage.
Yes.
Okay.
Can lead to graft loss also in 25%.
Okay. So what are the things you will kind of counsel before you go ahead with transplant? You'll ask, suppose if I am the patient, I am asking you, will I get the disease recurrence post-transplant or will I not get it at all?
He can get it, but chances of graft failure are more than 10 to 15 years.
So what are the risk factors for recurrence?
Yes, present in the when evaluation for native kidney disease, that time patient having a crescentric IgA or
So more than crescentic IgA, what is the current concept on that?
Some of the clinical parameters, some of
yes, sir.
Histopathological, clinical, the donor characteristics, immunosuppressive regimen characteristics.
Yes.
Yeah, you
So,
are saying, what you say is right, no crescent. Instead of crescent, now the current concept is that the burden of crescents.
Yes.
Because crescentic meaning, many a times, few glomeruli in the biopsy may have crescent, but it may not fulfill the definition of crescentic glomerulitis. We tend to downplay the occurrence of the partial crescent in few glomeruli, but you are not supposed to. Now, currently there are morphometric techniques are available which can totally assess the magnitude of the crescent. It's called crescent burden, which is an important risk factor. Then, of course, we said early progression.
Male gender itself and other
Donor status?
elderly donors are
No, living related versus deceased donor. Who is at a risk?
living
Then induction therapy based
induction
mesliximab versus ATG.
ATG carries lesser risk of
Will you venture with a steroid-free regimen in such a person with IgA nephropathy?
no, sir.
Not at all.
Not.
This is one situation where you should not go for steroid-free regimen because of pain problem. But the most important risk factor for occurrence of IgA post-transplant is
Histopathy.
the previous graft loss due to.
Oh yes, sir. Yes, sir.
That's it.
Yes.
Okay. Then,
just one small point.
Yes, sir.
This patient had a biopsy, so obviously his kidneys were not contracted
Yes.
at that time. So that's another important point that you should keep in mind, that some of the possibilities that have just been discussed, like reflux nephropathy, by the time those patients reach ESRD, kidneys are more likely to be contracted rather than have a size which is close to normal. So it's a relative point which goes against some of those possibilities.
and you prefer to use the word PTDM still? Nothing wrong in it, but it's your choice, but now it's no that.
No,
I saw a recent article
Yes, now
saying that
recent-
go back to PTDM. Yes.
So I'm pleasantly surprised.
It has
Why is it so, sir?
It doesn't.
I need to read in more detail, but I was also surprised. Yes.
Okay.
So otherwise, all this time we've been saying no dad, but now they're saying go back to PTDM. I'll be able to send you that article.
So they are different all the time.
And you said there was a Tacro dose was manipulated.
Yes.
They found Tacro C0 was high and that caused graft dysfunction. Can you explain to me why it happens? How
Sir,
come higher tacrolimus level causes graft dysfunction?
Acute CNA toxicity can, because of high TAC levels, may lead to apparent arterial vasoconstriction, intense vasoconstriction of the apparent arteriole. This can be secondary to thromboxane and endothelin. As a result, that will be
So at some point it's only hemodynamic effect.
Yes, sir.
At that point of time, if you reduce the dose,
yes. Reduce the
comes down
dose.
to normal. But are you not surprised that his net immunosuppression has been more than normal? But there was acute cellular rejection despite he being adherent to immunosuppression. How do you explain this?
CNA toxicity itself could have.
Oh, you said acute cellular rejection.
Sorry. AVMR could have.
In that situation, when the living related donor, mother, and the induction immunosuppression given, the acro level is more than optimal. When a tissue diagnosis of the graft biopsy is given as acute cellular rejection, what will be your thought process? How will you respond to that? Will you blindly accept that it is immediate rejection, or you would like to request the pathologist to rule out the possibility of something else that presents as acute cellular rejection? It happens the fourth month post
CMV infection also.
Not CMV.
BK virus infection.
BK virus. So, what are the common features between BK virus nephropathy and acute cellular rejection?
It can also present with interstitial inflammation and tubulitis.
Tubulitis. So, tubulitis is not 100% specific for this.
Yes.
So, what are the other situations where you get tubulitis?
TCMR, BK virus, and even CMV can cause.
No, CMV does not. One more virus?
Yes, sir.
Adenovirus.
Adenovirus.
And now currently he has diarrhea.
Yes, sir.
And again creatinine has gone up.
Yes, sir.
What are the possibilities?
Secondary to dehydration and leading to ATM.
Hypovolemia. So that's why I'm worried, because you said BP is 120.
Yes.
That is one possibility. There is no documented hypotension, but the creatinine goes up.
Yes, sir. It can be decoded because of diarrhea itself can cause increased TAC levels. So that can cause a graft dysfunction.
So how does it happen?
So these enterocytes will be expressing the P52, which is responsible for the enteric metabolism of tacrolimus. So that can cause TAC bypassing this pathway and entering into the bloodstream.
How MMF causes enteropathy?
MMS is basically IMPDH inhibitor, which is responsible for cell replication. The intestinal epithelial cells mostly depend on this pathway, where the salvage pathway is not active. So inhibition of this IMPDH can cause decreased cell replication and the shedding of the epithelial, shedding of the intestinal cells.
Which part of the intestine is most affected in histopathology?
Distal. Small intestine.
Ileum is also small intestine. Duodenum and jejunum.
Yeah.
Most affected. What is the pathogenesis of PTDM? Why it is more with tacrolimus?
Ma'am, actually tacrolimus will bind to this FKBP receptor, which is more expressed in the islet cells, whereas cyclosporin, which is due to cyclophilin pathway, which is less expressed in islet cells. So as a result, there will be islet cell and beta cell destruction, leading to more
What is the
hyperplasia.
recommendation of initial treatment for PTDM? OHA or insulin?
Initially, insulin we can
Recommended to start with
start with
insulin.
insulin.
Is there any studies with SGLT2 inhibitors in post-transplant diabetes?
Yes, ma'am, it is there, where very low, only 44 patients were included with SGLT2 inhibitors.
Is it recommended as of now?
As of now, it is not recommended.
Not recommended.
Out of the oral drugs, which is the first one you would use?
SGLT2 inhibitors, sorry, DPP4 inhibitors we can,
DPP, the first one?
or metformin.
Metformin. Yeah, metformin.
Is there no change in general recommendation post-transplantation? Is GFR is normal?
Only that SGLT2 are not as yet recommended, but off-label use, yes, you can. It's not totally contract.
So why you prefer insulin over oral hypoglycemic agents for treatment of this in early
Yes, sir, in
post-transplant
metformin also, since now it's lactic acidosis chances are more, so rather
Why insulin is preferred? You have
You
answered.
said you first use insulin, so why? That's what he does.
There is a rationale behind. I agree with you.
You said the pathogenesis.
yes, ma'am, beta cell destruction, so reduced insulin will be there in PTDM patients.
Beta cell protection is there because exhaustion of beta cells does not happen with the insulin supplement. So chances of subsequent developing permanent kind of the post-transplant diabetes mellitus becomes relatively less with if you are treating early PTDM with insulin as compared to your oral hypoglycemia. This is thought process, but many of the guidelines say you can even control with this oral hypoglycemia.
Also, when the PTDM is first diagnosed in a transplant recipient, most of the time the sugar levels are quite high.
Yes.
Because the patient is not on a restricted diet, and at that time the steroid doses may be higher, the TAC doses may be higher, so the levels may be quite high at that time. So you need insulin for that reason also. Whereas once you control the diet, reduce the tacrolimus as much as you can safely, reduce the steroids, the sugars come down, and then you are often able to switch the patient to oral drugs.
Yes.
So that's another reason, simple reason why you need insulin in the beginning, but not later.
Are you worried about a single episode of TCMR in the graph?
Yes, ma'am, a single episode of TCMR can predict a later.
90% is responsive to steroids,
Yes,
and
ma'am.
remaining will respond to your ATG.
Single episode of TCMR is a risk factor for future ABMR also.
Now considered as a risk factor
Risk
for
factor for
ABM.
future.
So what is the differential diagnosis of this acute graft dysfunction? You have told only this acute gastroenteritis could be there. But other than that, any other differential diagnosis do you think? If it is only because of the post gastroenteritis, you can supplement the fluid, it will become normal. So what would be your other differential diagnosis of this acute graft dysfunction which happens now?
So one could be because of acute gastroenteritis, the patient would have stopped the medications and that would have aggravated.
Stop the medicine. Usually, transplant patients are so smart they can stop anything, or usually they do not stop immunosuppressant.
Infective
What is the expected TAC level here?
elevated, no. So TAC toxicity can.
Already had one episode of TAC toxicity.
So tacrolimus toxicity during the diarrhea periods can be there, so that is fine. Second differential diagnosis. What else?
Even CMV
It is
testing.
easy to diagnose. You can get the tacrolimus level, it is high, collaborating with this graft dysfunctions. Yeah.
Other infective causes leading to acute graft dysfunction also, with presenting with diarrhea also.
Infections directly causing graft dysfunction.
Which infection you are referring to?
CMV can be one infection.
Same.
Yes.
CMV colitis,
Colitis.
causing diarrhea, and graft dysfunction due to indirect effects of CMV on the graft. That is possible.
So, do you think direct effect on the CMV or indirect effect on graft?
Both.
Yeah? What do you think?
Both can be there.
Both can be there. So CMV how directly affects the graft?
It can also cause tubular interstitial inflammation.
Sometimes the CMV can have acute interstitial nephritis kind of presentation. It is not that common.
Sometimes glomerulitis also can be seen with CMV.
Rare.
Rare. Now, all these are direct effects of this, are rare. Sometimes inclusion body has been demonstrated in the tubules, have been demonstrated in the vessels of the glomerulus, but these are all as a very small series or not that common. So most of the times it is the indirect effect which causes this problem. Do you think any possibility of rejection here? Should we keep any differential diagnosis, or you are totally sure that no, this is not a, because this patient has already one episode of the biopsy proven rejection despite having the normal tacrolimus level and everything, normal immunosuppression.
Something. Yes, sir. Rejection also.
So you want to put a
Yes.
differential diagnosis?
Yes, sir.
So how will you manage now? This patient has, everything is settled here. Only thing is the acute graft dysfunction for which this patient came here. So now you have to approach this patient and settle down this issue.
So it is his second presentation with acute gastroenteritis. Sir. Before 15 days only he presented, 7 days he was symptomatic, again 3 days after that again he developed. So rather I will consider stopping other non-immunosuppressive medications which could cause diarrhea. And after that I would go for a routine microbiological stool examination also. And in this patient which it was done CMV test also I would consider. And,
PCR negative will rule out the CMV colitis?
yes, no, ma'am. Tissue invasive CMV can have a CMV negative picture. Or else
You want to do
back-
colonoscopy and a biopsy from
colonoscopy.
the ulcers, isn't it?
So tissue PCR might help you whether this diarrhea, CMV associated diarrhea or not. You know. So that is the one. Other many more important investigations are now in the market where we can go for the uncommon causes of the diarrhea. Because here is the situation, patient has the recurrent diarrhea and you want to rule out before modulating immunosuppressants because the patient had rejection also. So rule out any infectious origin of diarrhea.
Yes, sir.
Yeah. So what are the different other? One you have told us about the CMV. We have ruled out. What else?
Clostridium immediate post-transplant.
So you will send the whole
Biofare, yes, sir. You can send a biofare of the stone.
now we have the viral panel for the different kind of the uncommon causes of the diarrhea, like the noroviruses and the adenoviruses.
PCR also.
So you will rule out. Suppose everything is negative. Yes, it is possible, quite possible, or you
Yes.
can get some uncommon kind of the virus, that is the some norovirus kind of things comes out.
Yes.
Cryptosporidium.
Cryptosporidium causing the diarrhea. Very common in our parts.
Yeah.
So what will you do?
So like to do a biofare test in that any isolated pathogen. Or if it is negative, then we have to consider last resort we should consider changing MMF. First you can change MMF to entry coated MMF tablet, and if it is still not responsive, then you can go ahead with other immunosuppression, stopping MMF.
So is there any difference in entry-coated or mycophenolate mofetil?
Yes, ma'am. There are some trials which have shown that
What's the
some
current
anecdotal reports.
thought process on that?
Really doesn't
Yes,
make
no,
There
it
is no
doesn't.
difference.
No.
There is no difference.
It is only tolerance a little bit might be better with this mycophenolate mofetil, but in terms of the side effects and diarrhea, how many patients of the mycophenolate mofetil develops diarrhea?
Have you heard of DIDAC study in the context
Yes,
of
ma'am.
post-transplant diarrhea?
Stepwise approach of diarrhea in transplant
The
patient.
evaluation of post-transplant
Post-transplant
diarrhea.
diarrhea.
So you have ruled out everything is negative now. So you will modulate immunosuppression.
Yes, sir.
You will stop mycophenolate mofetil and will change over to some other medications. What medication?
mTOR inhibitors I can
mTOR.
Or
azathioprine.
So your choice would be mTOR versus azathioprine. What will you
Monoclonal
do?
live related Isn't it?
Or before changing to mTOR inhibitor, what would be your criteria to see for? When you should do and you should not do. Normal clinical practice, I'm just asking. What are the two important things you would like to see in your patient?
Situation where you prefer mTOR inhibitors.
Any previous history of malignancies. So
Okay.
I would rather consider mTOR inhibitors. Any recurrent viral infections, also I could consider mTOR inhibitors because it has some antiviral properties.
तो इस पेशेंट में तो वायरस हमारा नेगेटिव आ गया है, एवरी वायरस वाज नेगेटिव, यू हैव tested with the biofile. So what other clinical parameters on examination investigations anybody will think of before changing to mTOR inhibitors? Is there any importance of getting the proteinuria done?
Yes,
Yeah.
proteinuria I can see.
So what is and GFR estimation? These are the two important. If GFR is less than sometimes 40-45, then or if the proteinuria is more than 1 gram, usually people do not prefer to use mTOR inhibitors. So that is the two important things before changing over the medications you must think of. So better to change from one antimetabolite to other antimetabolite rather than changing over to your mTOR inhibitors. So better replacement is always the. You have long experience of this azathioprine renal transplant recipients. One of the most experienced. So you will try to change over to azathioprine. So changing late from mycophenolate to azathioprine. So you are comfortable or anything you will keep in mind? So how you will change over? Is there any need to taper off it gradually or change over to this, or we can just stop this and change over to this?
Overlap should be there for a period of 2 weeks.
There is a recommendation of overlap of antimetabolite with antimetabolite.
No.
2 weeks, that means you'll be given 2 antimetabolites together.
So this is a usual mistake usually done. One antimetabolite to other antimetabolite does not use overlap. So you should be very clear in this. Otherwise the patient will be more immunosuppressed, getting 2 antimetabolites. So that should always keep in mind.
I think because you asked him the question, he went the wrong way.
So don't go by examiner will always try to trap you. So beware of that examiner's trick. So just tell me. So now you have the situation still the graft dysfunction is persisting. What will you do? You have you have finished off this diarrhea evaluation. Anything else more important? You have got the tacrolimus level done. You have done this diarrhea. Anything else?
In biopsy, I would rule out any
You know.
malignancy, PTLD. Sorry.
Why you are
Very rare.
jumping on PTLD?
Straight going for PTLD. Can there be
You
anything
are
else?
assessing the cause of graft
Graft
dysfunction.
dysfunction, yes. This is how many months post-transplant?
3
3
months.
months.
3 months. So,
Very risky.
what else would you look for? Early
In the
post-transplant
biopsy.
graft dysfunction.
Rejections.
So that you have already, rejection was already there once. You will look for it again also, yes.
Yes.
Agreed. What else? Supposing there is no rejection, can there be something else?
CNA toxicity.
Okay, that also is alright. That the level would have also given you some
Some
idea.
clue.
Some clue. Then,
Recurrence of any illness.
recurrence, this is relatively
Yes,
early.
So when you think of recurrence, when you think of rejection, what would be the clue on all your investigation, diagnosis and history that will say, no, I am recurrence, no, I am rejection. So there will be few pointers that will tell you. Tell me.
Native kidney disease, based on the native kidney disease itself.
Nature of nature.
Nature of native kidney disease, that is known in your patient, so that is fine. So there might be, if there is a remote possibility, histological difference might be there, moderate graft dysfunction. Yeah.
Anything else? Any other clues?
Sudden decrease in urine output.
Sudden decrease in urine output will suggest what?
Mostly rejection.
Mostly rejection. That will go in favor of your rejection if urine output is declined.
Yeah,
If urine,
the only exception could be a crescentic,
Crescentic,
de novo
Yeah.
or recurrent. Otherwise,
What else?
doesn't happen.
Suppose you are getting the routine examination urine. These are some clinical clues that should be in your mind when you are doing the routine examination urine. That is called liquid biopsy. So, surrounded tells this is liquid biopsy.
Any active sediments or proteinuria.
Proteinuria, if there is heavy proteinuria, that is not that common. Usually, degree of proteinuria which happens with the rejection are usually mild or moderate kind of, not a heavy proteinuria. If 4 plus proteinuria is coming down, serum albumin level is low, that will definitely go in favor of recurrence. If this is not there, so you should look into all these pictures to say this is the recurrence, this is looking like this. A small pointers that helps out in making this differential, particularly at this stage. And then
Coming back to what else at this stage could you find in a biopsy to explain graft dysfunction? You have mentioned rejection, you have mentioned recurrence. Besides that, anything
Irrespective of diarrhea, sir.
else? Yeah, irrespective of that.
BK virus also could
Yeah,
be.
so why don't you think of that?
sir, I already discussed किया आपको. So after this, because this patient, what are the risk factors for the BK virus nephropathy? Just tell me 1, 2, 3, 4, and then you will analyze your patients whether there is higher chance of developing BK virus in this patient or not.
History of patient received T cell depleting agent mostly. So that is one risk factor.
So this patient has not received.
Yes, received.
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 So that is one risk factor. So tell me.
The rejection itself would have caused higher immunosuppression.
You must have read BK virus nephropathy, so go and read about the tables. These are the risk factors for developing BK virus nephropathy, most of the study. There are many summary tables in many of the textbooks. So one is the depleting agent. On immunosuppressants, mycophenolate mofetil versus mycophenolate mofetil, some studies are shown has more chances of this. What else? History of rejection. Then treatment of the rejections. You have the other immunosuppressants are there. This patient had rejection, this patient had treated with this methylprednisolone again. So these are some risk factors in patients of even your patients. So you should be very clear in that. So you will like to exclude this BK virus nephropathy. And then definitely, what will you do to establish whether this is a BK virus or not?
I check for the blood levels. BK viremia is there or not. I would like to.
You like to do.
When you're talking of biopsy, in that, what will you ask the pathologist to do? Or before that?
SV40 staining I will ask.
SV40, yes, that's important. And what would you expect to see on light microscopy?
Light microscopy, interstitial inflammation and tubulitis can be seen.
इसके अलावा क्या रहता है कोई बोलता है नो येलो इज लुकिंग लाइक बीके वायरस नेफ्रोपैथी
Say BK
Inclusion
virus,
bodies.
not just any interstitial nephritis, not some specific features.
That's the inclusion bodies
Where?
and tubular epithelial cells.
Tubular epithelial cells here. So the nuclei, there is anisonucleosis and nucleomegaly. These are the two important changes. The nuclei enlarge and there is variation in the size of the nuclei. Some normal, some moderately enlarged, some severely enlarged. And of course, yes, interstitial nephritis, those features are there, tubulitis.
Interstitial nephritis, tubular, that is seen in many of the other conditions. Even drugs can cause this. Other infection can cause this. So, this nucleum, as soon as the pathologists see nucleomegaly, they hunt for finding out the evidences for inclusion bodies in this BK virus, or they will automatically go for the SB report yesterday and will tell you this is.
If you have both BK virus nephropathy and rejection ongoing simultaneously, how easy or difficult is it to make the diagnosis of rejection?
It's actually challenging to.
Yeah, it is. So how will you make
How will
that?
you take this challenge?
Associated presence of BK viremia could suggest more of a BK virus.
We are saying BKV is there.
BKV will or rejection will
And
The
also-
biopsy is the gold standard. So BKV is there. Now we are asking, is there also rejection?
Yeah.
Maybe there somewhere.
Yes, sir. SV40 staining for BK virus, and for C4D we can do for any rejections. ABMRs we can.
C4D, anything else? If you find microvascular inflammation, vascular change,
Yes.
that will be a point in favor of rejection,
rejection.
along with the other changes of BKV that we
Yes.
just talked about. Because just tubulitis, interstitial nephritis, those features of TCMR are common to both.
Yes.
So those don't help. But it's the vascular change.
In severe rejection, you might have this vascular changes. So that will suggest more pointers towards this. Rejection is also there.
And how do you manage if you find BKV? How do you treat that?
In biopsy, sir.
Yeah, we have confirmed it.
Yes, sir.
Now, what will you do?
Treatment of BK virus nephropathy. You can reduce the immunosuppression, mycophenolate.
Can reduce.
You have to reduce the
You
immunosuppression.
must immediately reduce. That's the only treatment really.
Yes.
The other treatments that have been tried, there's so many of them,
Again,
they
no.
don't usually work. So you have to, the key thing is early diagnosis, even before the creatinine goes up, if possible, and reduction of immunosuppression. So how will you reduce immunosuppression?
I'll better stop antimetabolics.
Yes.
And,
And
CNIs, I can give mTOR inhibitors, which is antiviral properties.
that is
So
one option.
CNI, we have to reduce the dose by 50%
but- Yeah, reduce the dose. Check the level.
and reduce it by
the
50%.
dose. And again check the level. And bring down the steroids also to the minimum
And,
dose. And if you have rejection along with it, then what would you do? That makes it even more difficult. Or sometimes after reduction of immunosuppression, rejection may develop.
So we can try with, first if rejection with BK virus is there, first you treat the rejection, and with high dose IVIG we can.
How to treat that rejection? Mainly, question is there, once you will give immunosuppressions, the virus is
You can
able to
consider
go up.
IVIG rather than going for a plasma.
Sometimes safe bet is the use of the IVIG. You know?
Yes.
So there are many, now there are few studies showing neutralizing effect of the IVIG on the BK viremia also. So that is the one safe bet.